Hi everyone, doing a quick sound check before we get started here. We still got 1 or 2 minutes to let everybody join us. If you have any questions prior to getting started, please feel free to ask me. The way we can do this is you can type your questions in that question box you see over in the GoToWebinar control panel. Those just come to me. The whole group won't see your question, but I can then either type an answer back directly to you, or I can answer out loud to the group if it's a question that I think would serve everybody. So let me know if you can hear me okay. I would also love to know when you guys are planning or already scheduled to take your NCLEX. That'll help give me an idea of where you are in your studying. So let me know those few things. We will give everyone 2 or 3 more minutes to get on. I think we have a group of about 50 joining us today. This is one of my favorite topics to lecture on, so it should be a good couple of hours here. All right. Got a couple of you taking at the end of January. Awesome. You're in the home stretch of your studying. That is fantastic. This is a good time to be taking these courses. Oh, ALI on Saturday. Awesome. Good luck to you. It's very exciting to be in the home stretch. A couple also in February. Very good. Very good. All right. Oh, Marcy's still waiting on her authorization to test. I remember being so frustrated waiting and waiting to get that email. All right. Well, I will go ahead and introduce myself. Please feel free to continue asking questions as we go. I will ask for you all to remain muted throughout these next 2 hours, just so there's not 50 different screens with noises bouncing around. It makes it hard to hear. Like I just mentioned, though, if you do have a question, I 100% want to answer you. So just type it into that question box, and I'll either directly respond to you via a chat, typing it out, or I can bring your question up to the whole group. We will take a 10-minute break halfway through. I need 2 hours. It's kind of a long time to stay focused. So I like to lecture for about 50 minutes, take a 10-minute break, and then lecture for that second hour. If at any point you need to step away and take a break, don't worry. More important that you stay focused and are able to really absorb all of the content today. A little bit about me, since I'll be blabbing at you for the next couple hours. My name is Morgan. I'm a pediatric nurse. I've worked on pretty much all of the different pediatric units throughout my hospital. PICU, a cardiac ICU, NICU, emergency department, bone marrow transplant. I love kids. I love how resilient they are. If you have any questions about becoming a pediatric nurse or any interest in that world, feel free to reach out to me. I really do love it. What I do currently is a little different. I'm the team lead for our children's resource unit at Duke University Hospital here in North Carolina, which means I kind of bounce around between all of our different pediatric units to help the nurses on those floors with any situations or patients that they need assistance with. So I get to be a resource on each of the different pediatric floors, and I love it. It's a little bit of everything that I enjoy. Fun fact about me, I did get married this year. Well, I guess I can't say that anymore. I got married last year in my backyard because COVID kind of ruined everything. So here's to a stronger 2021. And you guys are on the up and up because you're getting ready to take your NCLEX and become nurses. So that's an amazing way to start the year. All right. Are there any questions at all about me, about how our course works before we jump right in? What we're going to do for our first 50 minutes is focus on prioritization and delegation. So we're going to go over Maslow's hierarchy of needs, the nursing process, kind of the spectrum of stable to unstable patients, and what NCLEX buzzwords you need to look out for to figure out which patients are your priority. Then we'll go into delegation. We'll look at the scope of practice for each of our different healthcare roles and kind of talk about those 5 rights of delegation and the appropriate situations in which you can delegate so that you know how to get those questions right on the NCLEX. We'll take a break after that, come back, and then we'll do the second hour all focused on testing strategies. Now, throughout the way, we're going to be doing lots of practice questions. There's more practice questions within this PowerPoint than we'll probably get to today. I wanted to provide you with some extra content that you could have for self-study. So if I skip a question, you do have it in that handout. Speaking of your handouts, go to your GoToWebinar control panel over there on the right. And if you go down to that little bar that says handouts, you open that up, you have both the slides in PowerPoint format and a PDF handout of these slides so that you can download, print, save, and review as much as you need. So that's where those extra questions are if I skip one. All right, it's time to jump into prioritization. Nobody's asked any further questions, so I'm just gonna get right to it. And if something does come up, please let me know. First thing of prioritization, you are probably tired of hearing by now, are the ABCs. This is just the starting point of prioritization. You have to know this to be able to successfully answer those NCLEX priority questions, but it's not enough. So just remember, this is your starting point. A stands for airway, B for breathing, and C for circulation. So what is an airway problem? I've listed some of the most common things that we see on the NCLEX. A foreign body obstruction, so that's your 5-year-old that swallows a quarter, or somebody has an aspiration event. Obstruction, so that could be physical obstruction from a foreign body in the airway. That could be edema or swelling that occludes the airway. Or maybe your patient has an artificial airway, like an endotracheal tube or a tracheostomy tube, and maybe that tube itself is kinked. Any of those would classify as an obstruction of the airway. Edema, I already mentioned, is another way we can get airway obstruction through swelling of that mucosa. Our goal is always to have a patent airway. When I work in the emergency department, the first little thing I type in my note is ABC is intact, so our airway is patent. If we don't have a patent airway, so if you ever get a question with, which one of these patients is your priority, and one of them does not have a patent airway, that is your priority. We need to intubate, give them an artificial airway. If we cannot get them an artificial airway, we might need to do an emergency tracheostomy. If we don't have a patent airway, none of our other interventions are really going to do a whole lot for us. So that's always number one, is a patent airway. Moving on to number 2, we come to the B for breathing. That just means having adequate respirations. So in order to be adequately having sufficient respirations, you need a patent airway. That's why A comes first. We want our respirations to be an appropriate respiratory rate for the age. So in adults, that's going to be greater than 12. And we want them to be, profound enough to actually provide oxygenation. So if they're very shallowed, if they're very labored, those are not going to be sufficient respirations. This is also where you'll auscultate bilateral breath sounds. You'll make sure you hear good air entry into the lungs. And if any of those things are not happening, then their breathing is insufficient. So we need to breathe for them. And how do we do this? We use a bag mask ventilator. So that's your AMBU bag, right? And if the patient is not intubated, you'll have the face shield type mask that you'll use your little EC clamp to clamp down that mask and ventilate the patient. If they are intubated, that AMBU bag attaches directly onto the endotracheal tube or the tracheostomy tube if you have a trach patient. So number 1, patent airway, and number 2, that those breaths are adequate to provide oxygenation to the body. So if you've read down all your patients, they've got airways, they're breathing fine, your next priority, C, is for circulation. So that means, are they getting blood flow and oxygenation to their tissues? This one is a little bit harder to assess, and we need to look at their skin and have really good assessment skills to be able to do this. So how are their pulses? We want those strong +2 pulses. What about capillary refill? When you press down on the back of their hands or their sternum here, when it blanches, does the color come back in 2 to 3 seconds? Is their skin warm and of appropriate color for their ethnicity? Are they pale? Are they diaphoretic? Do they have weak, thready pulses and a prolonged capillary refill? All of those things mean that an insufficient amount of oxygen is getting to their tissues, which is poor circulation. So what do we need to do if our patient has poor circulation? If you read about that patient with +1 thready pulses and a 6-second capillary refill, we need to enhance their circulation, and there's 2 ways that we do that. Way number 1 is through fluids. If their blood volume is depleted and they have insufficient volume to meet those circulatory needs, we can give them some IV fluids, some normal saline, some lactated ringers, get that blood volume up, get their blood pressure up so we can get blood flow out to the tissues. Number 2, if fluids aren't cutting it and our blood pressure is really, really, really low, pressors. That's going to be starting your epinephrine, your dopamine, your norepinephrine, your dobutamine. That's going to be one of the last things you do for a circulatory issue. And I talked about those assessment bindings on our skin really, really well. There's one vital sign parameter that is really important when it comes to circulation I haven't mentioned yet. Any guesses on what that vital sign parameter is? Go ahead and type in that question box and tell me, what vital sign are you assessing when it comes to your circulation for your ABCs? You're going to keep your eye on this at all times. It's very, very important. Anybody? Not SpO2, not heart rate, not CVP, blood pressure. Good job, Amelia. Awesome. You're the only one who got that. Blood pressure is what I want you to keep your eye on when it comes to circulation. So that's just because, you know, the pressure in that vascular system is the primary determining factor to how much blood is getting from the circulatory system out to the body to provide oxygen to the tissues. So somebody said SpO2. That's a really good thought. We might see a decreasing SpO2 if we have poor circulation, but I'm going to think about that a little bit more when it comes to my B for breathing. If we're not getting adequate respirations, I'm going to expect that SpO2 to go down first. So I'm not saying that you wouldn't have trouble with your SpO2 when it comes to circulation. I just associate that a little bit more with the breathing priority than with a circulation priority. And then one person said CVP, or central venous pressure. Again, that is not necessarily wrong. That is pressure within your vasculature system. But do we have CVP readings on all of our patients as soon as they come into the emergency department? Definitely not. That is an invasive hemodynamic parameter where we need central access, and it's hard to get that immediately. And just the fact of the matter is the NCLEX isn't going to give you that parameter. I don't know if ever. I would have to look into if that's even testable on the NCLEX, because that's a little bit more advanced. What they do 100% require you to know is blood pressure. You need to know normal blood pressure ranges for each age, and you need to know if your patient's hypotensive. That's a clear indication that you have poor circulation, and then that patient becomes a priority very quickly. And again, we address that with fluids, and if fluids don't work, we move on to pressors. All right, so I mentioned that this is where we start. Let's do a basic priority NCLEX question to kind of kick things off, and then we'll move on to some more advanced priority concepts. So you guys read this. I'm going to give you about 90 seconds to put your answer in the questions box so that we can see, and then I'll review the answer with everybody. All right, there's our 90 seconds. Good job, most of you. All right, Blessy, Amelia, Gladys, fantastic. Discontinue dopamine for A, that is the correct answer. Let's review that together. So for A, your initial action there is absolutely discontinue the dopamine. Remember, that's one of our pressors or vasoconstrictors, so it's going to cause a squeeze of that vascular system. And that, because of that squeeze, elevates the patient's blood pressure. So because we had that elevated blood pressure, we need to immediately discontinue the dopamine. That's a circulatory issue, C. For B, that was incorrect. The nurse does need to notify the provider, of course, but that's not going to be your initial action. Your initial action is going to be to discontinue the dopamine, as that's what's going to immediately benefit your patient. In real life, I would be turning off that drip as I picked up my phone to call the doctor. And then C is incorrect. Of course, you can give furosemide if you have an order for it. It would help decrease the blood pressure through diuresis. But because the patient is on that vasoconstrictor, you need to terminate that, as that's the cause of their hypertension. And then for D, assessing their GCS, again, it's not wrong, but it's not going to help with your priority issue in this patient. Awesome job to those of you who got that one right. You did a really good job of using that ABC strategy to figure out what the priority issue was with the patient, which in that case was circulation, and you addressed that issue by turning off the dopamine. All right, there's another question after that I'm going to leave for self-study. And now we're going to go on to what I call the spectrum of stability. So this is adding on to your priority concepts of A, B, and C. Oftentimes, when you get these priority NCLEX questions, you read through the patients, you're trying to figure out which one is your priority, and none of them have an airway problem, none of them have a breathing problem, and none of them have a circulation problem. So your ABC strategy, you kind of strike out, you don't really have anything to go on. That's why I said it's a good starting point, but it's just not enough, because the NCLEX expects you to know who is the most stable and who is the least stable, and to be able to prioritize based on that spectrum. So I'm going to go over some words that the NCLEX uses to describe unstable patients and then stable patients. For your stable patients, those are going to be the patients that you are preparing for discharge. Your patient that would be safe to assign to a new graduate RN, or assign to an LPN. Or assigned to a float pool nurse that doesn't have experience in your specialty. They are chronic patients who have expected findings. So it could be your patient with asthma, but not a patient with asthma who's in an acute exacerbation. They're recovering, they're preparing for discharge, and we are expecting certain findings, like maybe they still have some bilateral wheezing. It's an expected finding in that chronic asthma patient. Again, getting ready for discharge, their lab values are staying the same. It's definitely a buzzword. If you see a lab value out of range, that patient is moving more towards the unstable side of the spectrum. Same with vital signs, consistent and expected vital signs. Not necessarily all perfectly normal. If you have a patient with chronic hypertension and they have a high blood pressure, it's an expected finding and it's consistent. So that's still considered a stable patient. But we don't want their labs or their vital signs or their assessment to be changing. We want it to be the same: stable, chronic, unchanging. Those are all of the words the NCLEX is going to use in their stems and in their answer choices to tell you that that patient is stable and therefore a lower priority. Now, on the flip side, your unstable patients are the ones who are having a changing condition. These are your acute patients that have unexpected findings. Maybe they were recently admitted. Maybe it's a new onset diagnosis. They have critical lab values. Their vital signs and their lab values are changing. Maybe they're hemorrhaging. They have an active issue that requires management. Those are your unstable patients. You might see words on the NCLEX such as they need to be transferred to the ICU. We need to assign them to a room closest to the nurse's station. We would assess that patient first. Again, these are your patients that have unexpected findings. They are in an acute phase of their illness. Acute will always take priority over stable. Changing will always take priority over unchanged or consistent. So these are your highest priority patients that you assess first, that you put in that room closest to the nurse's station. You would not delegate this patient. You would not assign them to a new nurse or a float pool nurse. Those are going to be your experienced nurses, and they're going to be the first patient that you assess. Okay, so I know that's kind of a lot of topics to, think about. It's a lot of different words. I think the best way to try and cement this knowledge is to do a practice question and talk through it together. So let me put up that question, give you guys a couple of minutes to look at it, think through it, and then we'll talk about how to use that spectrum of stability in this example question. All right. Good job so far, guys. It's a harder question. We're going to talk through it together. Nigel, you got it correct. Fantastic. Getting lots of different answers to this one. So we're going to go through it together. Amelia, that's correct. Awesome. Awesome. Hazel, yes. Okay. Let's talk through this together, guys. Let's go through each of the options together so that you can really understand how to use that spectrum of stability. So the answer was D, the patient who has chest pain after eating a spicy pizza 2 hours ago. If I had a guess, the reason that a lot of you didn't pick D was because he ate spicy pizza 2 hours ago and you're thinking it's just heartburn. Even if you're thinking it's just heartburn though, what else could it be? 2 hours ago, new onset chest pain. It could be a STEMI. It absolutely could be a STEMI, and that is an emergency. That is a very unstable patient. They're having changing assessment findings, and therefore they were your priority patient. The spicy pizza is kind of a random little fact that makes you think maybe this isn't so serious, but just because they ate spicy pizza does not mean that they're not having a heart attack, and it's not enough reason for you to deprioritize that patient. So when you're in the emergency department and you're triaging, it's those brief assessments to classify patients according to their need for care, which is just prioritization. So trauma, chest pain, severe respiratory distress, cardiac distress, limb amputation, acute neuro changes, those are all emergencies. Those are number one. Those are unstable, changing, bad vital signs, bad lab values. All of those are very acute. So that's where they fall all the way to the left on that spectrum of stability. They're very unstable. When we have things that are more like fractures, asthma that is not in complete respiratory distress, a fever, hypertension, abdominal pain, all of those things are urgent. We definitely need to address them, but they can wait. Those are kind of going to be priority number two. Though they're not completely unstable, they're not totally stable. Those fall in the middle of your spectrum. So they kind of are, priority number two. And then we've got all the way on our more stable sides are the people with a laceration, a sprain, maybe they have a runny nose or a cough. They are non-urgent. So let's read through each of A, B, C, and D and figure out which category we would put them into. A client complaining of muscle aches, a headache, and malaise that has been on for 5 hours. Is that going to be 1, 2, or 3 for you guys? Where do you put them on that spectrum? Muscle aches, a headache, malaise. Amelia would put them as a 3. Anybody else? You know they're not a 1 because we know D is going to be our number 1. And if I gave you 2 that were number 1s, that wouldn't be fair. Tenzin would give them a 2. Christina would give them a 2. I would also give this patient a 2. I would put them in the middle of that spectrum of stability. They have muscle aches, a headache, and malaise. The first thing that comes to my mind is meningitis. I want to ask them about neck pain, photophobia, what they've been doing leading up to this. Another key here, though, that you read in question A or answer choice A is that this has been going on for 5 hours. If they haven't acutely decompensated in 5 hours, they can probably wait another 1 or 2 hours and it's going to be fine. So that's why I would not prioritize or not pick answer choice A as my number 1 priority here. If we come on to answer choice B, a client who twisted her ankle when she fell while skateboarding. I think you guys can all know that is a priority 3. She can wait in the waiting room for a good long while. Answer choice C, a client with a minor laceration on the index finger. You see the word minor there, finger cut. She probably didn't need to come to the emergency department, did she? She could probably go to urgent care or her PCP. So that's definitely a 3. She's a stable patient. And then we go to answer choice D with that new onset chest pain. Remember, that patient is unstable because they are having a changing assessment finding. It's a very acute event, and that's what tells you this is an unstable patient that needs to be my priority. Okay, hopefully that was helpful. I know that this is complicated, and you've really just got to do a lot of practice questions. I'm getting a few questions up here, so give me 1 second so that I can answer. A few people saying handouts are not working. Okay, I sent a message to our head of technology who does all of that stuff so that he can fix it. That's not something that I am able to fix, and thank goodness, because I'm not technologically savvy. So give him just a few minutes to work on that and get it up and running. I promise we're going to get you guys those handouts. And then, will I have access to this recording on my account? Ashley, or anybody who's wondering about that, please shoot an email to support@archerreview.com to ask them if you can have access. I believe for the $10 or $7 that this short lecture costs, I don't think that streaming was included. But again, I'm just the teacher. I'm not in charge of all of that business stuff. So if you give them an email and ask them if you can have access to streaming, they may be able to work it out with you. Anytime that you guys have a need like that, support@archerreview.com, shoot them an email, and they have excellent customer service. They will get right back to you and try to help you out. And just give Kartik a few minutes to get those handout issues sorted out. I've never had that happen before, so I'm not sure why they won't let you guys download it. There we go. All right. Hopefully we get that all worked out. I hate technology issues. It's like I can never fix them. I was having computer issues last night and I was about to throw my computer out the window. Okay. On to our next prioritization concept. You guys are probably sick about hearing Maslow's hierarchy of needs, but it really does help when you read those NCLEX priority questions because there's a lot of good wording in here that's going to help you pick the right answer on the NCLEX. So obviously we start at the bottom with those physiological needs, the food, the water, the warmth, the rest. Those things have to be addressed first. So what are some buzzwords that you're going to see on the NCLEX that is about a physiological need? Oxygen. If you have a patient who's out of breath, you need to look at their SpO2. If they have low SpO2, that is a priority need. That would also be fall under B in your ABCs. So you should definitely know that that's a priority. Now we talk about food and water. So administering IV fluids, making sure your patient has adequate nutrition, either via a tube, via TPN and lipids, encouraging them to eat if they have a diet order, all of those things. Shelter, making sure your patient who's being discharged has somewhere to go. Elimination, making sure that you're taking care of their bowel and bladder needs if they're unable to do so themselves. And rest, promoting a normal sleep-wake cycle. Patients in the ICU can become very delirious when they get their days and nights mixed up because a lot of times they don't have a window and the lights are on all the time because we're going in and out of the room 24/7, and they just get all sorts of confused, and it ends up being really damaging to their mental health. So prioritizing those appropriate day-night schedules and prioritizing rest is a physiologic need. So those are the things I want you to think about first before we move on to our next tier, safety needs. This is pretty obvious in the hospital. We obviously need physical safety. So this could be maybe your patient has a change in level of consciousness and you think that they could fall. That is a safety issue. If they're going to trip over something in the room, if they don't know where they are, or they might be pulling out their lines, tubes, and drains due to that confusion with their level of consciousness change, that's a priority. We do need to make them feel safe. We do need to help with that psychological feeling of I'm in a secure place, because if the patient doesn't feel safe, it's going to be really hard to promote patient education and getting them to a healthier place. So all of those types of safety things, I feel like change in level of consciousness is one of the biggest NCLEX buzzwords that they use in their questions to alarm bell tell you that it's a safety issue. Definitely pay attention to that. After you've met their safety issues, next tier up is the belongingness and love needs. I see this a lot in our questions with therapeutic communication. Patients need social relationships. They need to feel accepted by their families, by their friends, in their intimate relationships. So you should be encouraging family support. You should also be evaluating if family support is actually helpful. If there's really challenging relationships or a certain person who's very toxic and not helpful to your patient, maybe asking them to step out might actually help with the belongingness and love needs of your patients. So that therapeutic communication and making sure your patient feels accepted in their relationships is your next priority. Fourth tier up, we get to our esteem needs. This again comes into play with therapeutic communication, helping your patient feel useful, accomplished, boosting up their self-esteem, self-worth, recognizing them when they do a really good job at something, and helping them feel respected. So this comes into play in therapy, in our psychiatric patients, maybe in long-term rehabilitation. We really, really hopefully are getting to the point where we've met their physiologic and safety and belonging needs, and then we can work on some of those esteem needs through therapy and therapeutic communication. And then lastly, at the very top, we have self-actualization, which we all know is achieving one's full potential, including creative activities. I feel like a lot of times as nurses, especially my whole career has been, emergency department, ICU, we never get to this point, we stabilize the patient so that they can survive and then, send them off elsewhere. But if you work in a more long-term care setting or maybe a psychiatric facility, getting to this point is probably even more important, because this is really, really what is going to provide the patient with skills to go on and live a fulfilling life. So it's recognizing full potential of self, effective coping strategies, problem-solving capabilities. It's, the being your best self, pursuing growth and talents, etc., are all things that you'll hear about in the self-actualization portion. All right, the NCLEX question for Maslow's, I'm going to leave you for self-study. I think that one is pretty easy and straightforward. But then I am going to come to this one right here. I think this is a great one to do together as a group. So you guys read this one, take a couple of minutes, and let me know what you think. The first thing that the nurse should assess. So I need you to think about your ABCs, your spectrum of stability, and that hierarchy of need. And I want you to think about, given that that lab value is very abnormal, what is the first thing that you really, really need to assess? This is kind of starting to put things together when it comes to priority. This is like the questions you're going to see on the NCLEX for sure, your higher level of difficulty questions. A lot of you guys are getting it. Really good job. Amelia, Marcy, Ada, Selena, Jasmine, Hazel. You guys are really doing a fantastic job. So yes, C, the respiratory status, looking out for those shallow respirations, is going to be your correct answer. A couple things that kind of gave that one away were the low serum potassium level. First and foremost, you had to know that 2.8 was a low serum potassium level. And secondly, you had to know what hypokalemia does. Hypokalemia affects many different systems, musculoskeletal, cardiovascular, neuro. We do not like it when potassium is out of whack. One of the things it does in that musculoskeletal system is weaken the skeletal muscles. Well, that includes the diaphragm. If the diaphragm is weak, we're going to have weaker and slower respirations, which can lead to a major issue with that B, or breathing, priority. Long rationale there. That can be one of the causes of death in hypokalemia if it goes unchecked and unrecognized. So definitely important to remember that side effect. C was your answer because B was the priority there. For A, B, and D, you do want to assess all of those things. Let me go back to the questions so we can look at each of them. For A, their balance while walking, absolutely important. We talked about that in the hierarchy, Maslow's hierarchy of needs, as being a safety issue. If those skeletal muscles are all really weak, they could fall and trip. So that's a safety issue. That's important. Quality of peripheral pulses, again, those could be weakened with the hypokalemia, but that's a circulatory issue. That comes into C. And then frequency of bowel movement, D. Hypokalemia can cause constipation, but that's really not falling anywhere as like a safety or physiological need. It's definitely not an A, B, or C. So you can cross that one off as a priority. Definitely C turns out to be your priority assessment in that patient, because that's the first thing that can kill your patient. That's a kind of a good way to frame it. When you're looking at questions like this and you're trying to think what's your priority, pick the killer answer. Pick the answer that could kill your patient the quickest. So, not balancing well while walking, that could be bad, but respiratory failure is going to kill your patient quicker. That's why I want you to pick the respiratory problem. All right, hopefully that's helping you guys a little bit. You got to practice, practice, practice when it comes to these priority questions. The more you do it, the better you'll get at it. Last thing I want to talk about is one more tool to help you figure out priority actions is really simple, the nursing process. You probably haven't thought about this since like first semester of nursing school, or maybe you guys still have to do those horrible care plans where you have to like write pages and pages on each of your patients about these. But as simple as it is, this can help you to pick out which action is the first action you're going to take on your patient. So you've got your assessment, that first step in the nursing process. You know, it's not just a physical assessment, it's all the data collection. Then you've got your data collection with subjective and objective data. Then you've got your planning phase. Then you've got your implementation where you're putting all of your plans into place and then evaluating how everything goes, right? Let's go through each of them and talk about some of the words the NCLEX will use to help you dial into that. And then we'll wrap up the prioritization part of this. So assessment, data collection. You've got subjective and objective data. Subjective data is going to be what the patient experiences or reports to you. So I'm in pain, I'm dizzy, I'm nauseous. And objective data is going to be what you can see as the nurse, their vital signs, their labs, their physical assessment. You get that data from the patient, from their family, from the lab report, your head to toe, from your chart review, all of those things. And then you interpret the data. You've got to know your normals as far as vital signs and lab goes. Remember with that last question, you had that potassium level of 2.8. And if you didn't know that that was abnormal, it made it a lot harder to answer the question. So know your normals. And lastly, I'd be remiss if I didn't remind you that you have to document your assessment. If it wasn't documented, it wasn't done. Next, we move on to the diagnosis part. So, of course, this is different from a medical diagnosis. Your nursing diagnosis is, analyzing all of that data. You're going to identify the different problems or what the patient is at risk for becoming a problem, and you're going to decide what the primary problem is. You want to use plain language to help identify and document all of this. The risks that you identify are likely going to be associated with the current complaint or problem that the patient is dealing with, and you're going to move into starting to put this together into a plan, your next phase. In that planning phase, you're going to be choosing your interventions and prioritizing them. So if your patient has an airway problem, addressing that airway is your priority. You're going to use those same processes and scales that we've just gone over to help prioritize your interventions. You want to develop those SMART goals and develop a plan of care that will help you achieve those SMART goals for your patient. The next thing you do is implement all of those plans that you just put into place. Do all your interventions, take action on your SMART goals, just do the things. That's your next step. And then lastly is your step of evaluating. See how the intervention affected the patient. If you gave an antihypertensive, did their blood pressure come down? You got to document all of that too, so that the future nursing staff knows if an intervention was effective and if they should continue it or discontinue it. So I know you know what all of those things mean. The reason I kind of did a quick recap on that, though, is sometimes you'll get these NCLEX questions where you have different actions to take, and it says, what is the first nursing action that you would take? And none of them are like, insert an ET tube or bag mask ventilate the patient or any insane big ABC or unstable versus stable priorities. They're a lot more simple. And so then if you fall back only on your ABCs, your stable versus unstable patients, it can be really hard to recognize what your priority action is. So if they're more simple nursing interventions, I want you to think back to the nursing process. You always assess your patient first. Assess is first. Then you diagnose. Then you plan, then you implement, then you evaluate. We follow that order of the nursing process every single day, and it becomes second nature. You don't always think about it, but the NCLEX forces you to kind of break that down and think about it more. So when you get that question, fall back on your 80 pie, fall back on the nursing process. I think 9 times out of 10, it's like, which is your priority intervention or which action would you take first? And there's an answer choice that says assess, blah, blah, blah. Assess is somewhere in that. And that's always going to be the answer because we assess first. All right, I'm going to let you do that question on your own. And we're going to take the next 10 minutes to talk about delegation. We might not totally finish delegation before the break. I want to make sure we take our time on it because it's a very important NCLEX topic. If there's anything you're still wondering about with prioritization, please feel free to put that question up in the question box and I can always circle back to it. But I'm going to plow right through into delegation so that we get a good way into it before we break. So we've got the 5 rights of delegation. Of course, you have gone over this time and time again. I'm thinking it might have been a little while though. I know I learned about it in like my first semester of nursing school and then didn't use it a whole lot throughout nursing school. The 5 rights of delegation are the right task, the right circumstance, person, communication, and supervision. We're going to go through each of those and just talk about how they rope into NCLEX questions. So the right task, pretty straightforward, is it a task that can be delegated? Is it within the scope of who you're delegating to, your LPN, your UAP? Is it a low-risk task? And is it actually within the scope of practice of the RN to be able to delegate that task? So we'll break this down more when it comes to scope of practice and when we go over which personnel can do what tasks, but that's always the first question you ask yourself when you're deciding to delegate is this task able to be delegated? If the answer is yes, then you need to think about the circumstance. So look at the big picture. What's going on with that patient? Are they stable? Are they unchanging? Are they chronic with expected assessment findings? If so, then good. If they are unstable, if they are an acute patient, if they have changing vital signs, I do not want you to delegate. I want the RN to keep that task. If they are stable and you've said, okay, yeah, everything going on with them is good, well, you also need to think about the circumstances surrounding the person you're delegating to. So if you've decided it's an appropriate task for the LPN, it's a stable patient, you also need to think about how much training that LPN has. Is this their first week? Are they brand new? How many patients do they have? Are they maxed out? Do they already have way too much to do? And do you feel comfortable knowing them and knowing their training with delegating that task? You need to make sure you think about all of that circumstance before you delegate. If all of that sounds good, you also need to go on to thinking about the right person. So that LPN that you're delegating to, again, do they have the appropriate training? How long have they been on this job? Do they have experience doing this specific task? Are they competent, and should you delegate to an LPN or a UAP? We'll talk about those scope of practices in a little bit because I know that's kind of where we get hung up in our questions, but making sure that you are delegating to the right person is your next right of delegation. Fourth, we'll talk about your right communication. You always have to explain what you are delegating. Nobody's a mind reader, so make sure you set very clear expectations about what you want them to do surrounding that task. Do they need to report back to you? Should they be documenting on this task? If they say you've asked an LPN to go do an INO cath, do you want that LPN to come back to you and tell you how much urine output they got from that cath? Do you want them to just put it in the chart and move on with their day? Do you want to know their assessment of the urine? Do you want to know what it looked like? Do you want them to come and get you when they're done so that you can go in the room and do something? Set all of those expectations very clearly and use that closed loop communication. And lastly is right supervision. When you delegate as a registered nurse, the accountability for the action is not delegated. You are ultimately responsible for making sure that that task was completed in a timely manner, appropriately, and documented appropriately. You have to follow up on all of that, and you should ensure that it was done properly. It's not appropriate to just say, hey, I need you to go cath room 6, thank you, and walk away and go into your next room and not think about it for the rest of the day. Maybe that LPN had way too much going on, they couldn't get to it, and then that patient never got cathed. That would fall onto you as the RN. So that right supervision, although it seems kind of funny to include it in a right of delegation, is super, super important. Okay, I'm gonna go through the UAP, the LPN, and the RN to talk about scopes of practice before we take a break. Because ultimately, as long as you can follow those 5 rights of delegation, knowing the scopes of practice is really what you've got to be able to memorize to get those NCLEX questions right. Because you know you're going to get a question that says, we'll give you some context, and then it'll say, which of the following tasks can you delegate to the LPN? And you've just got to know this, okay? First and foremost, I want to say that it does vary state by state and facility by facility. So once you're out in the real world as big grown-up registered nurses, always check your facility protocol, because what you studied for the NCLEX might vary from what your facility follows just a little bit. Here are the basics that I practice in North Carolina, so I say the North Carolina Board of Nursing. But the Board of Nursing sets forth when we look at the NCLEX test plan. So these are the things that you need to know hands down when you take your test. A UAP, or an unlicensed assistive personnel, that includes your nursing assistant, your CNA, your NA. The things that they can always do are ambulate, help with turns, bathing, all of those ADLs, intake and outputs, oral care, toileting, feeding. They can take vital signs. They cannot interpret vital signs, but they can take vital signs. Weights, linen changes, all of that jazz is perfect to delegate to a UAP. So think ADLs, think hygiene, think basic care. They can never do anything regarding an IV. They can never administer medication, assess a patient, and they are not able to delegate. It is not within their scope of practice to delegate any of their tasks. Next, we have our LPN, our licensed practical nurse scope of practice. Again, duties will depend on the state, the facility, and the specific LPN's training. Some of these LPNs may have been working for 20 years and have trained on certain competencies and be able to do a lot more than I have listed right here. But for the sake of the NCLEX, you don't know that. So you need to know what the Board of Nursing says is appropriate for all LPNs, which is what we have here. So they can do everything that a UAP can do. Ambulate, turn, bathe, oral care, toileting, feeding. They can also do vital signs. They can also gather data. So that's a step up from the UAPs, right? They can do some of those basic assessment and data gathering positions. They can also take care of stable patients. So when you think back to the prioritization and we talk about that stable patient with expected vital signs, with unchanging lab values, that's preparing for discharge, that's the patient you would assign to your LPN. Things that LPNs can never do are teach, educate, assess, plan, evaluate, interpret, and take care of unstable patients. Now, when you look over here on that no side, the teaching, the educating, the assess, the plan, that sounds a whole lot like the nursing process that we just went over, doesn't it? That AG pie. Well, that's because it is. The nursing process in general is reserved for registered nurses, okay? So use that as a standpoint to help you think about what you should not be delegating to your LPNs. If it sounds like they're planning, they're implementing, or evaluating, that should be an RN task. And if it's a unstable patient with changing vital signs, really unstable vital signs, or dramatic shifts in their lab values, that is not the patient that you delegate to your LPN. A couple of questions before we move on to our RN. Feeding vital signs, sometimes positioning for unstable clients. Okay, so they're asking if a UPA, an unlicensed assistive personnel, can do the ADLs, like the feeding and the turning, etc., for unstable patients. I'm going to say for NCLEX purposes, no. If your patient is unstable, I do not want you to delegate. That's one thing that on the NCLEX test plan, it states pretty clearly, is that you do not delegate an unstable patient. I'll give you a good example of why you don't want to delegate anything, even as simple as a turn or a reposition to your unlicensed assistive personnel. I was taking care of a very, very unstable patient in our pediatric cardiac ICU about 2 weeks ago. She had been doing a little bit better. She had had a heart transplant, but she was still very unstable, had changing vital signs, changing lab values. I repositioned her. I turned her onto her left, and she had a full-on cardiac arrest and a 2-hour-long resuscitation event. So when you have an unstable patient, even as simple as a turn, a feeding, etc., you should not be delegating those activities. Unstable means registered nurse. And then LPNs can reinforce teaching or education. Yes, very good distinguishment, guys. Reinforcing is within the LPN scope of practice, but initial teaching and education, admission assessments, anything that happens for the first time needs to be reserved for the registered nurse. Reinforcement of education is a good NCLEX buzzword of something that you can delegate to your LPN, just not that initial education. Okay, I think that took care of our questions. Feel free to shoot more questions at me as we go. Last one we have to go over is the registered nurse's scope of practice. So I'm kind of falling back here on our nursing process, your assessment, your evaluation, your teaching, education, any medications, anything with an IV, your blood transfusions, developing your care plans, all of that are things I want you to automatically think registered nurse. If you see that task, it should not be delegated. One point that I have for you before we break from the Board of Nursing: the licensed nurse who delegates responsibility maintains overall accountability for the patient. So that is directly from the Board of Nursing. I took that directly from how the NCLEX test plan to reinforce with you guys that when you delegate something, even though you send responsibility to the LPN to go do that cath, or to the UA to go start that feeding or whatnot, you as the registered nurse maintain accountability for the patient. The licensed nurse can never, ever, ever delegate their nursing judgment or any activity that will involve nursing judgment or critical decision making. So that's why we can't delegate education. That's why we can't delegate admission assessments. It involves nursing judgment and critical decision making. We can delegate the reinforcement of teaching because the initial teaching's already been done and we're just going to be reinforcing. But with our initial education, you have to be able to make that nursing judgment on how well the patient is receiving that education. If we're teaching in a way that they are able to really receive that education and that they can demonstrate understanding to you. And that involves critical decision making. So you're not able to delegate that. So this is a direct quote from the NCLEX test plan from the Board of Nursing. And I think it's really important to drive home because of the need to supervise anything that you delegate and know that you retain accountability for that patient no matter what. All right, one more question before we move to break. How about ostomy care and enteral feeding? Those are tasks that you can delegate to your LPN. Those are within their scope of practice. Enteral feeding can be delegated. That's an ADL that absolutely is perfectly acceptable for the LPN. And then ostomy care kind of goes along with the, elimination and the bowel and bladder needs, like a cath, an INO cath. Those can all be delegated to the LPN. Now, what if you had a patient that was getting ready to be discharged, you're doing ostomy care and getting ready you're trying to teach them how to take care of that ostomy at home. If it's the first time you're doing that teaching, you're going to need the RN to do it. And so that you can kind of clinically evaluate if they're understanding that ostomy care and make that decision. If you're reinforcing the teaching, absolutely, LPN can do it. And if you're not doing the teaching, if it's just routine ostomy care, LPN can do it. Can LPNs give opioids? Yes, LPNs can give medications. That does vary state by state. As far as the NCLEX goes, the LPN can give opioids. It might be a 2-nurse check. They might have to dual sign it with another nurse, but they're not restricted from administering that medication. And can LPNs do IV placement? Again, that's going to be facility by facility. For your NCLEX purposes, they can do IV placements, especially LPNs that have been working for a long time. That's absolutely a skill that they have. It's just that they have to be competent at their certain facility. Which is the same for RNs, which is the same for any of us as healthcare providers, is you're going to have to be checked off on any of those skills. So, and then some of those say LPN give narcotics. The LPNs can give narcotics, absolutely. Should we assume that the LPN is not IV certified for NCLEX purposes? Good question, Amelia. I don't have a perfect answer for you on that, just because it does vary so much facility by facility. I'll see if during the break, I'll see if I can find something directly from the NCLEX test plan to give you a better answer on assuming if the LPN is not IV certified. I know lots of LPNs who are very competent in giving, in inserting IVs, so I wouldn't necessarily jump to assuming that they're not. But let me see if I can find something directly on the NCLEX test plan so that I don't mislead you. Go ahead and shoot any other questions at me, and I'll do my best to get you a really clear-cut answer. We are at over our halfway point, so I'm going to let you guys take your 10-minute break now. You've got another delegation question there that you can do on your own for some self-study. So send me any other questions you've got. Take 10 minutes to get some water, have a bathroom break, and we'll come back at 3:10. Is that the right time? I think so. Yeah, 3:10. I'm in a different time zone, so I was trying to get it for Central Time. So I'm going to mute myself. I'm going to address any questions you guys shoot my way. And then when we come back at 3:10, I will jump into our testing strategies part. Alrighty. Hopefully everyone had a good break. Give everyone a few seconds to get back on. And let me circle back. The two things I had written down were administering narcotics and initiating IV access for LPNs. So the NCLEX test plan does not give you a perfect, crystal clear answer on yes, they can, no, they can't, because it depends on the state. So I did find a list online of which states allow it and which states do not. So you can refer to that for a super specific answer. For the purpose of the NCLEX though, because that's all that matters right now, if the question says that the LPN is, like competent in their state, then you can't really assume one way or the other. They're not going to try to trip you up by asking you, can this LPN insert an IV, and you don't know what state they're in, because it would be impossible for you to answer that. You don't have enough information to be able to answer that correctly. Nobody does. So don't get too hung up on those two specific things. I did see a lot of states that allowed LPNs to administer narcotics via oral pain medication, but not intravenous narcotics. So it gets super specific depending on the state. So don't assume one way or the other. And just know that the NCLEX is not going to give you an impossible question. They're going to make sure that you have enough information to be able to answer it. Otherwise, it just wouldn't be fair for you. So that's what I've got for you. It's unfortunately not black and white. You're going to find that a lot in nursing. If you have any further questions about it or any other ways I can potentially clarify it for you, please do let me know. In the meantime, I'm going to jump into our testing strategies. This is my favorite part, and I really think this is where you get a lot of bang for your buck. I'm going to go through, I think I have like 10 to 12 strategies that I find work really well on NCLEX style questions, and we're going to do some practice together, okay? So, strategy number 1, eliminate what you know is wrong first. So you're going to look at each answer choice individually. They are independent of each other. And if you know it's wrong, just go ahead and mark it out. Cross through it and don't think about it any longer, because it is not correct. Now, if part of the answer is wrong, that means the whole answer is wrong. So mark it out. Let's do a practice question to emphasize that. Good job, Blessy. Good job, Gladys. Ashley, excellent. Amelia, good job, good job. All righty. That's perfect, guys. So really what I want to drive home here with the correct answer is C. Place the uncapped needle in the sharps container immediately. Very, very good. What I want to emphasize with like answer choice D, it says cap the needle and dispose of it in the regular trash. So that whole thing is wrong. You know that you're never going to cap a needle. So you're going to cross that answer out. B, place the needle in a biohazard bag. You know that's not right. A, cap the needle and place it in the sharps container. So you see place it in the sharps container was right, but you saw cap the needle, and it's never correct to cap a needle. We know that's a safety issue. So because it said cap the needle, part of that answer was wrong. The whole thing was wrong, and you can just cross that out. So that's my strategy number 1. Cross out what you know is wrong. Another question there for you. I told you there's lots of questions in here for you guys to practice on your own, okay? Practice makes perfect. My next strategy, number 2, group drug classes together and remember what their names look like. It is so impossible to memorize every single medication in your Davis drug guide, and you don't have to. I don't know every medication in there. I never will, because I have resources at the hospital to help me when I see a drug that I don't know. So study the major groups from your pharmacology crash course. And if you haven't taken that, we're going to be offering it again soon. So you should definitely sign up for it. And then learn what the names in that group sound like. I've got some suggestions over here on the right like ending in PAM, lorazepam, diazepam. Those are your anti-anxiety agents. So if you remember what they sound like, if you get one on the NCLEX that you've never heard of, maybe clonazepam, and you're like, clonazepam, I don't think I learned about clonazepam, but it ends in PAM. I think it's an anti-anxiety agent, and I did learn about those. So you can apply what you know to a larger number of medications, and you're way more likely to get things right. I promise you, you're gonna see a medication you've never heard of on the NCLEX. I bet I could take the NCLEX tomorrow and see a medication I've never heard of. But I'm pretty good at knowing my pharmacology groups and knowing the major nursing actions in that group, and that will be enough to get you by. All right, question, strategy number 3. If a question asks you who is the most at risk or the most likely, etc., I want you to tally up their risk factors and choose the patient with the most. So it might be that they all have some risk or some likelihood of whatever the question is asking you, but the right answer is going to be the patient who has the most. 3 risk factors wins over 2. I know that sounds really self-explanatory, but these questions are tricky. So I think this is a good one to do together. So let's read this together. Which of the following is most consistent with a patient who has hypothyroidism? We'll read through those and use my strategy of tallying up all of the assessment findings consistent with hypothyroidism. Then you can tell me who is the most consistent. Good job, Gladys, Tenzin, Christina, excellent, excellent. Good job. So for D was correct, everyone. You saw the slightly obese female, periorbital edema, cold intolerance, brittle hair, dry skin. 5 assessment findings that are consistent with hypothyroidism. For C, thin, no, male, no, hoarse voice, facial edema, thick tongue, diarrhea, no. So he only had 3. D wins. For B, obese, perspiring, no, feeling cold, diarrhea, no. B only had 2 risk factors. And A, thin, no, anxious, no, exophthalmos, no, rapid pulse, no, diarrhea, no. Those are all hyperthyroidism. She has no assessment findings consistent with hypothyroidism. So there you go. D had 5. She was the most consistent with a patient with hypothyroidism. There you go. Simple as that. It's straightforward in how it sounds, but as those questions get tougher, it can be hard to say who's the most likely or most at risk. So always use that strategy where you tally up their risk factors. All right, next test strategy. Don't pick an answer if you don't know what it means, because if you haven't heard of it, I doubt anyone else has either. Remember that you are a brand new nurse, and the NCLEX knows that. They expect you to be a brand new nurse with 2 weeks of general nursing knowledge. So if they throw something crazy out of left field and you're like, I have never heard of that word in my life, don't pick it. It's probably wrong. Simple as that. All right, next strategy for you guys. Know the why behind signs and symptoms. Oh, I'm super glad that it seems like most of you are taking your NCLEX either later this month or in February, because all of these things we're talking about today, the management, prioritization, delegation, have to come last. You can't prioritize if you don't already know your core content. If you're struggling with some of these questions and you're like, man, you know, I understand prioritization, why can't I get these right? You need to go back and look at your core content. Everything relies on that. You can't prioritize something if you don't know about the disease and about the disease process and nursing interventions. Knowing the why behind all of those things and why the signs occur, why symptoms present themselves, is really, really going to help you get to the right answer more efficiently. So I want you, there's 3 examples here that seem to come up on the NCLEX all the time. All right, why So why something is happening. So the first one, polyuria. Way too much urine output leads to a fluid volume deficit, and it leads to shock. So when you see polyuria, I want you to think shock. Next, heart failure seems to come up a lot. What is heart failure? The pump is not moving blood forward. We have decreased blood flow to the kidneys, therefore decreased urine output and retention of fluid. That is why we see edema in heart failure patients. Next, hypoxia. We don't have enough oxygen getting to the tissues. We don't have enough oxygen getting to the brain. When the brain is hypoxic, the patient gets very anxious and has a level of consciousness change. So that's why hypoxic patients are anxious. When you see anxious patient, I want you to think hypoxia. So those are just 3 examples that I see on NCLEX questions all the time. But this general test strategy of knowing the why behind signs and symptoms will help you with every single NCLEX question. You have got to be able to think through why something is happening, and that will help get you to the correct answer. Okay, I had one question pop up. Explain one more time, first slide. Okay, so that first slide, let me go all the way back. Hold on, guys. Was eliminate what you know is wrong first. So for that testing strategy, that just means that when you read through the answer choices, if there is an answer choice that you know without a shadow of a doubt is incorrect, like for example, in our NCLEX question right here, you saw in question A, cap the needle and place it in the sharps container. You know without a shadow of a doubt that you should not cap a needle. That is a safety issue and you would never cap a needle. So you know that answer is wrong and you eliminate it. You cross it out and you don't think about A for one more second. You move on immediately to the next answers. What sometimes people do is they really start to overthink these answer choices and they think, okay, well, the sharps container, that is where we put needles. So, maybe A could be right. And that, you start to spin out and obsess on thinking about that. So what I'm trying to tell you is if you know that it's wrong or part of it's wrong, eliminate it and move on. Don't waste your time on it anymore. That's what I meant by that first testing strategy. Okay. Know the why. All right, we're going to do a practice question for know the why behind signs and symptoms. So I think that's an important one. And look, heart failure. I told you, heart failure is all over the NCLEX. And this is a select all that apply. Make sure to read. For everyone that's answered so far, go back and do it as a select all that apply. Good job, Gladys. You're the first one to get it. Awesome. This is hard. It's like, it's not that hard of a question, but it's kind of trips you up. Okay, there's 3 correct answers, A, B, and C. Which one of the following heart sounds would the nurse expect to auscultate in her patient diagnosed with heart failure? Select all that apply. All right, so in heart failure, we think about a patient in heart failure. Okay, what is the physiology there? The pump is not working, blood is not moving forward, we're not getting enough blood flow to the kidneys, so our urine output drops and we retain fluid. We become very fluid overloaded. Now, I'm pretty sure every single one of you picked C because you thought, oh my gosh, okay, heart failure, fluid overload, S3 is that gallop that we see when patients are fluid overloaded. So you picked C and you moved on. But this was a select all that apply. Okay, so that wasn't even the testing strategy that I was getting at with this question, but make sure to read the entire stem. Make sure to know if it is a select all that apply, because do patients in heart failure lose their normal S1 and S2 heart sounds? No, they just get an extra heart sound for all that fluid overload. So we hear their normal S1, we hear their normal S2, and then we also hear their abnormal S3 because of that fluid overload. So A, B, and C. Now, what I was getting at with this testing strategy was I need you to know why patients in heart failure retain fluid and how that manifests in your assessment findings. You need to be able to think through that to answer this question correctly. And if you had forgotten that we sometimes hear S3 in heart failure, you could then think through the physiology between heart failure and that retention of fluid, and then you could figure out that S3 would be an appropriate answer. We'll talk about some select all that apply strategies in the future questions, so don't get too hung up on that. But really just remember to know the why behind your assessment findings. Okay, on to our next strategy. Think like a new nurse. I hit on this a little bit earlier, but the NCLEX does not expect you to be an expert, because you're not. I'm not an expert. It's going to take me 20 years to become an expert. They do expect you to have 2 weeks of general nursing knowledge. So you don't need to know everything, but you do need to keep your patient safe. So always protect the patient. The NCLEX is a safety test to protect the public. All it's doing is making sure that you are going to be able to keep your patient safe when you are out in the world practicing. So you don't need to know every single drug in the world. You don't need to know crazy, long fetched diagnoses that no one has ever heard of. You just need to know how to keep your patient safe. So when you're looking at questions and you're trying to figure out, what's your priority, or, what do they want me to pick? They want you to pick safety. They want you to protect the patient. They want you to assume the worst and fix the problem. If there is a question about something, there's something to worry about. Not everything is not fine. There is something going on. There is something that you need to address. So be a worrywart, be a pessimist. As a nurse, not just even on the NCLEX, as a nurse, you need to be a pessimist. You need to go into the room and look for what could be about to kill your patient, and then you need to fix that problem. So when I walk into my room, I'm looking at where's my bag mask and is my suction plugged in and working, because at any moment they could have a cardiac arrest. I am assuming the worst and I am prepared to fix that problem at the drop of a hat. So you need to take that approach to your NCLEX questions. You need to look at all of those answer choices and figure out which is the killer answer. Which answer could kill my patient first, and what do I need to do to protect them? If you have that kind of mindset thinking about your NCLEX questions, you will pick the question or pick the answer that they want you to pick. All right, I'm going to save that question for self-study. Now, next one, something I'm sure you've heard of. This won't trip you up too much. Pick the least invasive option first. So if you have a choice between a non-pharmacologic and a pharmacologic intervention, we're going to try the non-pharm first. Reposition, hot and cold, dim the lights, make the room quiet. And then if we do go on to medications, we're going to pick a non-opioid before an opioid. We're going to try Tylenol or Motrin, or maybe even Toradol before we go on to oxycodone and morphine. If we have a patient in rehab, we're going to try therapies like PT and OT before we go to doing surgery. And this is an important one right here. Restraints are always a last resort. If there is anything else as an answer choice that you could do for your patient, such as redirect them, try to reorient the patient, try to calm them down, maybe they have a PRN medication available, anything at all, you're trying that before you try the restraints. Trust me, as a nurse, you don't want your patient in restraints because you have to document on them all the time. If they're violent restraints, you have to document every 15 minutes, and you do not have time for that. So you want them out of restraints ASAP. Try everything else possible before circling that answer for restraints. The NCLEX really doesn't want you to pick it. So I'd be very, very hesitant to choose the option of putting your patient in restraints if there is anything else that you think you could do. Okay, next strategy. I think this one is hard for people sometimes. Only call the healthcare provider if there is nothing that you can do as the nurse for your patient. If there is any at all immediate intervention that you can do to help, that's what you need to do first. So we saw this in an NCLEX question earlier when you had a patient that was acutely hypertensive on a I think it was dopamine or dobutamine. They were on a vasoconstrictor and their blood pressure was like 190/100. So did you want to stop the dopamine or call the healthcare provider? You guys picked correctly that you need to stop that vasopressor. There was an immediate intervention that you could do as the nurse to help the patient. That is always correct. Another example that I see all the time on the NCLEX is the prolapsed umbilical cord, that OB emergency where we've got the umbilical cord squeezed between, the baby's head or presenting part and the cervix, and it's cutting off blood flow to the fetus. So they start to have those decelerations in their heart rates. So you as the nurse can lift the presenting part of the fetus off of that cord to restore blood flow. You need to do that before calling the healthcare provider. And again, in all reality, you're lifting the presenting part while you scream out the room for help and somebody comes running. But when you think about it in an NCLEX-y way, your priority is to help the patient. Your priority is to keep them safe. And if you as the nurse can do something for them, do that first. Only call the healthcare provider if you are not able to help the patient in any way. So let's do a practice question on this together. I see people kind of trip up on this pretty frequently. Oh, good job, guys. Lots of answers. Bless you, Gladys. Oh my gosh, I can't keep up. Halak, Hazel, good job, good job. Okay, everyone who's answered, you've got it right. Awesome. So you know this important nursing action. Cover the site with a sterile dressing. That is something that you can do to help your patient immediately. That's going to prevent air from entering the pleural space. You're going to tape it down on 3 sides so that air can escape and it doesn't cause a pneumothorax. And then you're going to immediately call for help and get your healthcare provider in the room. But your priority is covering it with that sterile dressing to help your patient. Really, really good job, everybody. All right. For priority questions, and we've done a lot of these today, pick the answer most likely to kill your patient. This is what I meant when I said pick your killer answer, because remember, the NCLEX is a safety test. They want you to protect the public. So pick the answer most likely to kill your patient. Pain will never kill your patient. Hypoxia will. Acidosis will. Respiratory distress. Losing a patent airway. Some arrhythmias will kill them. Your fatal arrhythmias, VTAC without a pulse, VFib, and asystole. If any of those things are going on, you need to act very quickly because that can kill your patient. Hypoxia and acidosis, I just want to highlight before moving on, because sometimes I think we kind of forget about those as something that can very quickly kill your patient. Hypoxia, that's kind of falls in either your airway or your breathing or your circulation. It's kind of all over the place, but you see that lower SpO2, your circulation assessment with those pulses and cap refill is really crummy. Or you've got that really restless, anxious client. They're picking at the sheets and they just feel like something is wrong. That's the brain starting to run out of oxygen. So you need to act very quickly. With acidosis, you're mainly going to start to see that on lab values, maybe in your arterial blood gas, but that's another one where you will note level of consciousness changes. As the level of acid builds up, their blood becomes more acidic. The brain is really not a fan of acidosis, so you'll start to notice an altered mental status, and it can be deadly if not treated in a timely manner. So make sure to address those as priorities over pain, priorities over anxiety, priorities over really pretty much anything else. So those are things that are going to fall under your unstable patients. Some of those are in your ABCs, and you just got to know that can kill your patient, so you need to be on the lookout for it. All right. We'll do a quick question here. I think this is a good one because you have to evaluate some vital signs. Ooh, okay. If you haven't had pediatrics yet, this is going to be a hard question. Okay. All right, only a few of you got this one. So the first thing I want to point out is that we're picking up on some very specific assessment findings. First of all, this is a 4-year-old. So you need to think about respiratory problems in the 4-year-old, and then you need to read your assessment. Tripod positioning, so we know they're leaned forward, they're having trouble breathing. Blue lips, have some acrocyanosis, so this is a bad circulation issue. Mottled skin, that's also poor circulation. So we're having airway breathing problems and circulation problems so far. Inspiratory stridor, so very noisy breathing as they inhale. So that usually means upper airway obstruction. So we have an airway problem too now. And excessive drooling. Excessive drooling is an NCLEX buzzword for a certain pediatric respiratory problem. If you know what it is, type it in the chat. I want to see who knows it. Manjeep got it already. If you don't know this, you're not going to know the answer to this question as hard as you try. Good. Okay. Gladys, Ada. All right. Epiglottitis. We see excessive drooling with epiglottitis. Epiglottitis has what we call the 4 Ds: drooling, dysphonia, dysphagia, and what was the other one? Ugh. My notes in front of me. The reason that we're seeing all of the drooling, the dysphonia, the dysphagia is their epiglottis, that little flap of tissue that covers the trachea while we swallow, is super swollen. So that ends up creating an airway obstruction. That's why we had our inspiratory stridor. We look at our vital signs. They are hyperthermic. They have a fever that occurs with epiglottitis. They are tachycardic, they are tachypneic, and they are desaturated. So we know that this is an emergent problem. This patient absolutely would be sent to the ED from urgent care because we need to intubate them. They could lose their airway very, very quickly. We have an airway problem here, so our priority action is addressing that airway. In epiglottitis, we intubate the patient to secure a patent airway, because when that epiglottis continues to swell and swell and swell, it's actually going to obstruct the entire airway. And once it's obstructed, it's very hard to insert an endotracheal tube. So you end up doing an emergency tracheostomy, which we would like to avoid if at all possible. So the priority nursing intervention with those patients is to keep them calm and call for emergency airway equipment. They have to be intubated by a skilled provider very quickly. And if you cause any sort of reaction or make them upset, where they are screaming and crying, they can have laryngospasm and their entire airway will close off. And at that point, the provider's not going to be able to insert an endotracheal tube. So we absolutely do not obtain IV access. We are not poking them. We are not assessing the throat. We are not using a tongue depressor. We are not swabbing the back of their throat. A lot of you picked D, place the child on high flow nasal cannula at 100% FiO2. That sounds like a great answer. It really does, because they're desaturated. Their oxygen is in the 80s on room air. We need some oxygen. Now that is a B priority. That's a breathing priority because they're desaturated. The A priority is airway. They are losing their patent airway. And if we put that high flow nasal cannula and flow a bunch of liters per minute of air down the back of their throat, they are going to vasospasm, constrict, and lose their airway. That's why they need to be intubated. We need to deal with the airway problem before the breathing problem. So if you've taken some of my PEDS lectures, you know I am very passionate about this topic. The priority in epiglottitis is always going to be keep them calm and call for emergency airway equipment. So this is a good example of you have to know your core content before moving on to these priority and these delegation questions. The strategy here, pick the answer most likely to kill your patient. The thing most likely to kill your patient is losing their airway. So getting them that airway is your #1 priority. A couple of questions. Can epiglottitis be intubated? I mean, ET. So Tenzin, do you mean like inserting an endotracheal tube? Yes. You would want a skilled provider to insert an endotracheal tube as soon as possible. And then Ashley asked, do we go over this in PEDS? I'm still working my way through the videos. Yes, Ashley, we definitely go through epiglottitis in PEDS, one of my favorite lectures, so no worries, you will get to that in those videos. All right, everybody. On to our next testing strategy. Hopefully that was helpful to kind of break it down. All right, this one's pretty straightforward. If the answer puts work off on someone else, it is wrong. The NCLEX really wants you to take responsibility for your patients and your nursing tasks. So they want you to be doing the work. If you're saving it for the next shift or, you know, saving it for somebody else to do, that answer is absolutely not the one you should pick. Another important point is if the answer is ignoring what a patient says, then it's wrong. We really want to focus on patient-centered answers where we're listening to the patient, taking their concerns seriously, and using therapeutic communication. Super, super important to stay patient-focused. So, for example, if a patient tells you a concern they have, maybe they want to think about using alternative therapies, or maybe they're, you know, considering a different treatment course, and you just say, you know, oh, that's not a good idea. We shouldn't talk about that. That's not therapeutic. You've got to stay focused on them, and when you've got to take their concerns seriously, you should never just brush off a patient's concern. So I think I have a question about this one. Pretty straightforward, but we'll kind of hone in on our therapeutic communication a little bit. Good job, everyone. Fantastic. C is the correct answer here. So again, you have to know what an umbilicale is. It's when those intestines protrude through the umbilical cavity. That's a birth defect that needs to be repaired surgically. So we don't typically swaddle these infants. We typically have their intestines in what we call a silo to help gradually put them back into the abdomen and repair it surgically. But if we look at these answer choices, we have, you know, a parent who's wanting to swaddle their infant, which is therapeutic and helps them bond. So we absolutely don't say, stop, you'll kill your baby. That's not going to be therapeutic. That's not going to help that poor mom or dad bond with their baby. We don't want to tell them that's a nice tight swaddle, because we don't want to swaddle them tightly. That will harm them. But also we come down to D and just telling them swaddling is not allowed, please stop. That is not taking the parent's concerns, wants, or needs into consideration. So by staying focused on the parent, asking, may I help you, and explaining we need to be careful with their intestines. Maybe you just kind of swaddle them below the waist, or there's a little thing I do called a Batman swaddle, where we put a wing around their arms in the bottom, and they look silly, but it leaves their intestines out. So there's ways that we can work around that, where we communicate therapeutically with the parents and with the patients and help them form that bond. So these are pretty straightforward. I know sometimes people struggle with picking the right answer when it comes to therapeutic communication, but really, if you just try to use common sense, think about what you would want someone to say to you if you were in that situation, and focus on patient-centered answers, you'll be fine. All right, last strategies here are going to be about select all that applies. Oh, I know everybody hates select all that applies. I hate select all that applies because it seems like it's like 5 questions in one. And that's how I want you to think about it. Every single answer choice is just another true or false question. There is no relationship between them. You could have 5 right answers. You could have 1 right answer. Select all that apply gives me anxiety too, Amelia. Like, it's just, it could even be an easy question and it's like so much harder because it's select all that apply. So I just want you to treat every single answer choice as true or false. Don't think about them in relation to each other. Don't freak out if you all think all 5 are right and talk yourself into not picking one because it must not be that. There are no rules. All of them could be right. One of them could be right. It doesn't matter. There's no relationship. Let's practice it together. So you guys, you got to get in the habit of doing this with your select all that apply questions. Good job, Marcy. This is hard, guys. Dina, really good job. All right. Okay, so let's go through each one as a true or false question together. You've got a 62-year-old. He was prescribed Qbank. He got persistent watery diarrhea. Whew, what are we thinking? He has C. diff. Very unfortunate. So what precautions are you going to take? Select all that apply. Okay, this boils down to, okay, should I do this for C. diff precautions? A, should I sanitize my hands before and after entering the room? Almost all of you picked A, but A is wrong because with C. diff, we don't sanitize. We wash our hands with soap and water. Remember, with C. diff, we have to do special enteric precautions because the spores are not killed by sanitizer. So if you sanitize, you still got C. diff on your hands. And trust me, you don't want to bring that home. So you got to wash your hands with soap and water. I know this is such a mean question. This really tricks you. All right, so A, you say, nope, I'm not going to sanitize before and after C. diff. I'm going to wash my hands. So you cross off A. False. Okay, now you come to B. All right, place the patient in a negative pressure room. You think, should I place my C. diff patient in a negative pressure room? Well, it's contact special enteric, and we only use negative pressure rooms with airborne. So nope, I'm not going to place them in a negative pressure room. False, cross that one out. Now we come to C. Should I wear an N95 and a face shield with my C. diff patient on special enteric precautions? Again, I'm going to do that with my airborne patients. If they've got TB, if they, have, COVID, any of those, I would wear my N95. C. diff, no, I'm not going to do that for C. diff. So I'm not going to do C, cross it out. Now I have D, use single-use equipment and leave it inside the room. I am going to do that with contact. I'm not going to bring anything out because I don't want to bring those spores out and spread it. So yes, I'll do D. So I picked D. That's it. I'm not going to freak out that I only picked one answer. I'm not even going to think about that I picked only one answer because I independently evaluated all my choices. I decided A was false, B was false, and C was false. D was true. So I circled that one and I moved on. Don't think about it any more than that. You gotta do a lot of practice of these ones, guys. Practice makes perfect. Okay, this is my last testing strategy. Oh, hold on. Joelle asks, what part of the question made you think it's C. diff? Okay, Joelle, this is how I knew it was C. diff. He had an infection. We put him on a broad spectrum antibiotic, and then he developed persistent watery diarrhea. That screams C. diff. It's after you're on an antibiotic that wipes out all of that good intestinal flora and fauna, so you just don't have anything left, and you get this horrible, horrible persistent watery diarrhea. Anytime you have a patient developing watery diarrhea after an antibiotic, we're going to test that stool for C. diff and go ahead to empirically put them on that special enteric antibiotic. So that's definitely something that you should be able to recognize on the NCLEX and think, okay, what safety precautions should I put them on to prevent the spread of this to other people? Okay, hopefully that helped. So last testing strategy, super, super important, guys. Don't freak out when you get a question on a topic you don't know. It is going to happen. Remember, you're a new nurse. You're not going to know everything. I don't know everything. None of us do. It's totally, totally fine. So just fall back on your core content and think about what you do know. Remember those whys that we talked about. Why do heart failure patients get edema? Why does polyuria lead to shock? Why is my hypoxic client acting all anxious and crazy? No, think back to those processes and apply it to this question. Eliminate what you know is wrong. So if you've got an answer choice that talks about something and you know that's not how it works, even if it's not in relation to this new disease process that it's talking about, if you know that that's not how it works, eliminate it. If you know it's wrong, don't think about it any longer. Just cross it out. And when push comes to shove, hopefully you've gotten it down to at least 2 answer choices by crossing out what you know is wrong. Pick the killer answer. Pick the answer most likely to kill your patient. Protect the public and just be confident that you can fall back on that core content at any time. So this really just kind of puts all those testing strategies together and tells you that you're gonna get questions that you have no idea what it's about. And honestly, that's a good thing. That means you're getting to those higher level questions and the computer adaptive testing is getting closer and closer to cutting you off and saying, hey, you passed, you're a nurse. So it's okay. Be glad that you're getting hard questions. Fall back on your core content and follow this process. Use that process for your select all that applies. Use that tallying up process for the most questions. Remember your priority scales and just fall back on methodically answering these questions. Honestly, the best thing you can do is practice, practice, practice. The more practice questions you do, the better you are going to be able to pass your NCLEX with flying colors. So I'm going to wrap this up by just kind of talking about upcoming courses that we have and how I recommend that you study for your NCLEX. It was what worked for me, and it's what I've seen work for tons and tons of students. So first and foremost, we have 2 more crash courses this month. We've got mental health on January 7th from 12 to 2, and then we've got a 3-hour fundamentals course on the 15th from 2 to 5. So if either of those topics are something that you'd like to go a little bit more depth in, join me back here on those days and we'll dive deeper into them. Now what I want to talk about is our full rapid prep review course. And it sounds like some of you have either purchased the video access or have already taken it. But this is a 2-day, 20-hour full NCLEX review course. It's going to be on the 21st and the 22nd. And what we do, we have 4 different sections. So in part 1, we talk about our fundamentals. That's our lab values, our ABGs, our EKGs, our growth and development, our safety, et cetera, et cetera. Those basic things that you've got to know to kind of build on and get to your other stuff. Part 2 is our longest. That's system by system. And we break down, neuro, cardiac, respiratory, and go through the basic anatomy and physiology that you need to build on. And then we hit on the high yield concepts that you've got to know. So for example, we'll go over strokes in neuro. In respiratory, we'll go over pneumonia and a few others. I'm not going to talk about every single disease that you ever learned about in your med-surg textbook. Don't ever pull that thing out again. Don't read it. Nobody knows everything in those textbooks, but there's things that the NCLEX asks about a lot. So I'm going to talk about the high yield topics. What nursing interventions you need to know, what meds you need to know, what assessment findings you need to be able to pick up on. We're going to hit those high yield concepts throughout our systems. Part 3 is specialties. So we're going to do the same thing for our pediatrics, my favorite, OB, mental health, and oncology. Hit those high yield topics to tell you what you need to know on the NCLEX. And then part 4 is going to be somewhat similar to this crash course where we go over prioritization, delegation, and those testing strategies and do practice questions. This was even more in-depth because you did the in-depth crash course on testing and prioritization, but that's how we finish up our rapid prep course. The last thing we do is a cumulative NCLEX exam. 20 questions from across the spectrum to give you an idea of where you stand, where you might need to work a little harder, and where you're already doing really well. So it runs from 8 a.m. to 6 p.m. Central Time on that January 21st and January 22nd. If you are not available on those days or part of those days, or you just cannot swallow the idea of listening to me for 10 hours, 2 days in a row, that is a-okay. Go ahead and sign up anyways, because when the course ends, you're going to get 3 things. You're going to get the slides, the handouts, well, 4 things, the practice test, and you are going to get on-demand streaming access for a whole month. So even if you can't be here or it's just too much for you to take consecutively, you're going to be able to work your way through those videos on your own time. Even if you do attend in live, over GoToMeeting, you can still review those videos to really reinforce the concepts that you need a little bit more work on. So definitely sign up. For a lot of you that are taking your test in January or at the end of January or the beginning of February, it would be the perfect way to kind of wrap up your studying and really cement all of these high yield concepts and practice a lot. So my recommendation is to take that rapid prep course with me on the 21st and 22nd. Then the next thing I would recommend you do in your studying is review that rapid prep course. Listen to the videos again and make notes. Make skeleton notes on all of those high yield concepts to try and cement them in your memory. And then go and teach them to a friend. Once you can confidently teach your core concepts to a friend, you are ready for the NCLEX. That's my favorite study strategy. I used it all throughout nursing school, was to teach it back to my roommates. We would practice lecturing back and forth. And once we could honestly, without looking at our notes, teach a concept to each other, we knew we were ready for the exam. The last recommendation I have is to sign up for the Archer Review Question Bank. We've got over 2,600 questions on there. You go on there, you pay for however long you want access to it. I think you can do like 1 month, 2 months, or 3 months. And then you tell the computer which types of questions you want. You can just do like all, you can do just certain topics or styles of questions or difficulty levels, how many questions you want, blah, blah, blah. It generates the test. You take it. You have 2 really important things. You have super detailed answer rationales for every single answer choice. Because I cannot tell you how many times during my nursing school career, I would get a question wrong and the instructor would be like, well, it's A because it just is. That's just the right answer. And I was like, I don't understand why I got this question wrong. And that's super frustrating when you're like doing this over a computer, right? And studying for the most important test of your life. So all of our answer rationales go in depth, every single answer choice, so that you, even if you got the question right, you can learn from those rationales because you know why each one was right or wrong. The other really important thing that that question bank has is a average peer review score. So once you finish your test, it's going to show you how you match up to the other people taking the tests. And once you are meeting or exceeding the average peer review score, for our students who have diligently gone through the question bank and are meeting or exceeding the average peer review score, we have a 99% pass rate. So I'm telling you, practice makes perfect, guys. Go through that question bank. And once you're beating that score, you are ready and you can feel confident about it. So I really want you guys to sign up for that rapid prep course, take it with me and do our practice exams, because I promise we are going to get you there. All right, I've had a bunch of questions pop up while I've been blabbing about all of this. So let me circle back to make sure I answer everything. I got to scroll up. We got a lot of questions. Okay, a couple people saying unable to download the handouts. So we are not super sure why the handouts are not working. Thus far, we've had no issues. So Kartik is working to figure it out. But when this ends, he's going to send you an email with the handouts. So don't fret, the email has not been sent yet because I'm still teaching. But as soon as I end it, then he's going to send you the slides and the handouts to your emails that you registered with to make sure that you get them. Trust me, he will not forget. I will not let him. Okay, our next question from Ashley. Are the questions Archer uses all passing level questions? I'm assuming they are. Absolutely. Archer focuses not just on passing level, but on the highest level questions. So of course, we have a variety in our test bank with 2,600 questions, but most of them are going to be the more difficult questions because we really want you to focus on understanding how to get those right. And then once you take the NCLEX, you'll be like, oh, that was so much easier. All right, next question I have from Christina. If I've purchased the full Rapid Prep Review, is the mental health and fundamentals review courses any different than what's included in the full Rapid Prep? Really, really good question, Christina. I should have talked about that. So fundamentals and mental health are both absolutely part of our Rapid Review course. But these crash courses that I have listed go even more in depth. So the Rapid Prep is going to give you the basics of everything you need to know to pass the NCLEX. I'm going to hit those high yield concepts, but I'm going to go really, really fast, okay? The fact of the matter is cramming the NCLEX into 20 hours of instruction is a challenge. So when I say Rapid Prep, like it's rapid. We're moving fast, y'all. That's why you get access to review and review and review. So if you're really struggling with mental health or you really need some extra TLC in the fundamentals category, 100% go ahead and sign up because there is additional content, additional practice questions, and we go way, way more in depth. To give you an example, I think we dedicate about 45 minutes to mental health in the Rapid Prep, whereas our crash course is 2 hours. So we're going to go way more in depth and do a lot more practice questions to just bolster your knowledge there. Let's see. I have another question here. Is the cumulative 20 question test part of the videos that I bought? So actually, I don't have access to see exactly what it is that you bought. So I'm going to recommend that you email support@archerreview.com to ask them, just because I'm not privy to your account and I don't know what package you bought and what it includes and what it doesn't. So I'm sorry I can't give you that answer, but just shoot them an email and I'm sure that they'll get you what you need. Hi, I just logged in. Can I get the video access? Okay, Lakita, no problem at all. We're going to make sure everyone gets the video access. I've said this a few times. Once I end the video is when Kartik will send you that email with the streaming access and the slides and the handouts, etc. It's just since I haven't ended it yet, he's not been able to do that. So be a little bit patient, but it will come your way. Mandeep, how do I remember medicines? Awesome questions. That's one of the hardest things, right? Is remembering all those medications because there's so many of them. My recommendation is to group medications together by their therapeutic action and their class. So like anti-anxieties, antihypertensives, and learn about them as a group and remember kind of what their names sound like. For the anti-anxieties, they all end in PAM, diazepam, lorazepam, clonazepam. So don't spend too much time learning about every single one. Learn about them as a group and remember what the medications sound like. We do have an in-depth pharmacology crash course. We previously did a 2-hour one. We're actually revamping it to make it 3 hours so we can add some more practice questions. So be on the lookout for that in February. If you're not already taking your NCLEX by then, definitely sign up for that pharmacology crash course because I'll go through it class by class, just like I mentioned, and then pick an NCLEX buzz medication off to check out. Depth and you learn about it. Yes, Lita, everyone will get the handouts to your email. No worries at all. Susie asks, I want to know, Rapid Prep course is enough for those who graduated a long time ago. So that's a hard question for me to answer specifically because I don't know you personally and I don't know how long ago you had your school and what's changed. Rapid Prep review course is designed to do is take 20 hours to go over the high yield concepts in every single category. So when I was designing this course, I literally had the NCLEX test plan on one side of me right here, and then all my notes and diagrams and stuff over here. And I pulled out the stuff that I saw coming up on that test plan over and over. So I went through it very methodically, but do I include in rapid prep every single thing you will ever be tested about on the NCLEX? No. First and foremost, there's no way that any test prep company could ever do that. It's too much content to cover in a reasonable period of time. And I mean, it would just be impossible to cover every single medication, every single disease process possible to go over. So instead of attempting to do that, I picked out the things that we see on every single NCLEX exam, every time, just over and over, and really focused on the why to help you have a thorough understanding, so that when you get questions about something you don't know, kind of like I was talking about in my last test prep strategy, you have the foundation and the capability to figure it out. So it's impossible for me to tell you, exactly what's perfect for you. I think rapid prep is the perfect starting place for your NCLEX test prep. If you feel like you're struggling to keep up during rapid prep, then you might need some additional reading materials, and we can work with you to support you in that. You might need some additional crash courses and practice questions, etc. But I think it's an excellent place for anybody to kind of start and end their NCLEX test prep journey. People asking about getting access to the rapid prep course. So you'll register for that the same way you registered for the crash course today on our Archer Review website. And if you're not attending live, once the course concludes, like the following day, you'll be getting an email with access to the videos, the handouts, the tests, the slides, all of that jazz. So you don't have access to it right now because I haven't taught it yet. It's a live course just like this. So if you are interested, just please go ahead and sign up on our website tonight. Don't wait. Next question. Webinar is Central Time. We always post our reviews in Central Time. I'm actually on Eastern Time, so for me, it's always an hour later where I'm at. But 8 a.m. to 6 p.m. Central Time is the time that we are on live. And Kartik just put in the chat, you will all be getting a follow-up email, which has all of the links to register for any of these courses. So if you're interested in that mental health crash course, the fundamentals, the rapid prep, you're going to get a follow-up email that has links for registration. So you don't even have to go on the Archer Review website. It'll be easy peasy in your inbox. Share it with a friend. It's more fun to do it together virtually. So yeah. Let's see, another question. How consistently should we be above average peer score before we know we're ready to take the NCLEX? Every time that you do it, you should be above average. So she said maybe like 3 to 4 times. It depends on how long of tests you're doing, because you can generate, a 10-question quiz, a 25-question quiz. I would say that you want to generate like a 75 to 100 question test to simulate actual NCLEX situations, and you should be able to consistently get above that peer review 3 times in a row on those longer NCLEX exams. Because if you're just doing it on like 10 questions, it's going to be less reliable since it's less data to go off of. Yeah, so you guys are going to get that follow-up email with links to register for these great courses, the handouts, the on-demand access to this webinar, which you just attended. I'm getting all flabbergasted. So don't worry, that's all coming to your emails so that you have all of your resources from tonight's webinar and the access to sign up for our future ones that are going to be fantastic. Another thing that Archer Review has going on is Pulsed In. You can go to pulsedin.com. You can also download it from the App Store. It is a social media platform just for us nurses, so you can engage and involve in quizzes. We've got podcasts that are made, on like 8 to 10 minute little topics that you can listen to. You can interface with other nurses, job network, all sorts of awesome stuff. Definitely go download that app. You'll see the upcoming review courses and stuff pop up there. Really, really great place to kind of like see all of the different cool things Archer Review is doing. Another question about sharing some tips on the study schedule and how to balance between theory and question. Ooh, you know, that's hard because it's kind of different for everybody. So I can share with you kind of what works for me, but by no means do I want you to think what works for me is like perfect for everybody. It's really, that's very, very personal. So, I would say that for me, I would spend the first chunk of my time studying the lectures, studying the core content, writing out those skeleton notes, and practicing teaching back and forth to my friends. And then I would take a break, and then I would end my day doing the practice questions. That really depends on how much time per day that you work studying for you. I don't want you to think that you have to do it a certain way. But I would say that first and foremost, committing that core content to memory and just knowing it without a doubt or hesitation is your first priority. And then your second priority is doing those practice questions over and over and over until you beat that peer review score every single time. Ashley asked the name of our app again, so that's Pulsed In. Actually, I should pull it up on my phone and show you guys so that you can see it and see what it looks like so that you can download it. So, trying to just get to like what it looks like so you guys can see. Oh my gosh. I'm not, I told you guys I'm bad with technology. I'm also bad with my phone. Okay, so it's this white one with the, oh my gosh. The little panel is in the way, so I can't like tell if I'm showing you guys. Oh, it doesn't even, you can't even like see it. It's this white square with the little blue like squiggles, and then it'll come to this screen where you sign in, and then you'll see all of the awesome stuff on there. It's a really, really excellent resource. So Pulsed In. Sorry, my little demonstration was not very effective. You'll have to download it for yourself. Awesome. Oh, and a note from Kartik, our data indicates if you score high or very high on 4 consecutive assessments, then you have a 99% pass rates. So if you click that button, the create an assessment, under like test or tutor mode, when you select that button, then it automatically creates a timed test just like the NCLEX, which is really excellent to kind of simulate those conditions. You know, sit down, give yourself the appropriate amount of time, no distractions, and just knock it out. And once you can consistently score high or very high on 4 of those NCLEX like timed assessments, you know you're ready. So that gives you some reassurance. And the name of the app again, Pulsed In, P-U-L-S-E-D in, Pulsed In. All right, excellent. I really hope that this was helpful for you guys today. I love lecturing on this topic. I think it's really important to use as you study. So please let me know if you have any further questions. We're past our time, so I'm gonna go ahead and end this so that everybody can go on with their night. I know here it's like already dark. It's gross weather out today. So thank you for attending. I really hope to see you in our rapid prep course at the end of January. Remember, you can sign up even if you can't attend on those days. I promise it's going to be awesome, awesome content for you guys. Please send us any feedback, anything I can do better. We really strive to give you guys the best in NCLEX test preparation. I know you're all going to be awesome nurses, and I can't wait to work with you. Have a good night, everybody.